Okay, let's go ahead and start from here, right where we needed to pick up from. I'm going to talk about sexual health. It's a little hard for some to have this conversation with their patients. However, over time, if you do your own homework and start kind of realizing the cause and effect relationship of what sex means to people, then you might feel a little bit more comfortable holding conversations regarding sexual health. By definition, come on, go. There we go. By definition, it's basically the state of emotional, mental, and social well-being related sexuality. So when we start having these conversations about sex, knowing whether somebody has a satisfying relationship in the bedroom, or knowing if they prefer to be with males, or knowing if they prefer to be with females, all of those kind of details will actually affect the other aspects of their health. So it's hard to ignore sexuality because it is so involved in everything else somebody does. As I kind of briefly joked in class, if somebody is a rock star in the bedroom, they're going to probably have more confidence, maybe be more physically fit. I mean, there's just a few things that play into the role versus if they had been raised in an abusive relationship. What is that going to look like for their health habits? So knowing somebody's sexual health can definitely be beneficial. For healthcare workers, you need to remain and convey openness toward people and their tendencies and preferences and behavior patterns, and give them an opportunity to talk freely and talk to you without them feeling like you're going to discriminate. Once again, it's really hard, especially if you have personal convictions of somebody's behavior and lifestyle. However, just continue to be open, try to see it from their point of view, and just promote health, promote health, promote health. So, to move forward, we need to know the theoretical knowledge of sex, sexual expression, and problems affecting sexuality. Okay. Here we go. Gender. Who is a girl? Who is a boy? Typically, it is defined by the gender that you were born with. For our friends who are hermaphrodites, those usually will get tested with how much hormones they have, and when one level is higher or the other, the parents can actually choose for them. I actually have a family friend. His child was a hermaphrodite, and they decided after all the data that they had, even though it's not conclusive, that they were going to raise their child as male. And so unfortunately they had an accident whenever the child was 8 years old, so they never really got to see the the development of this child. However, it goes to say that kids don't really identify which sex they are more like until they're in like the school age years. As you can see here, there are pretty typical roles for males and females to identify in. Males are usually more dominant. They have they are better when it comes to, oh, hey. Okay, sorry about that. So, goodness, I wasn't sure where I'm going. Yes, so typically when you're born male or you're born female, society will help you be assigned into those roles. So what is considered, in my opinion, a positive, today parents encourage androgyny, which is the blending of masculine and feminine roles. So a woman, if she wants to be educated, she could go to college and get those skills of being the doctor or the lawyer, being a breadwinner. So, and then same for a male. It's okay for him to go into like fashion design and art, things that are more feminine or commonly known as feminine. So everyone has both skills, traits, and behaviors. A stay-at-home dad is more and more common. Let me go to the next one. Next, here we go. Gender identity. So basically, the terms that come to mind whenever you think gender identity, the first one should be, well, obviously, heterosexual and homosexual. So that's, well, excuse me, that's my next slide. Let me back myself up. Transgender. It's a broad term used to describe people whose gender identity differs in some way than their biological gender. So in one way or the other, they are transgender. And there's different categories of being transgendered. You could be transsexual, you could be intersexed, you could be a cross-dresser, and you could also be heterosexual, homosexual, and bisexual. So, transsexual now, this is sort of what we saw in the video today. These are people who identify with the opposite gender from their biology, from their birth gender. So they feel and perceive themselves to be something that's opposite. So it's common, though, for transsexuals to express dissatisfaction with their gender at an early age. So if you are doing your assessment on a pediatric patient, and just from your observations and maybe even talking with a parent, like how do they play, the parent may explain to you that they play with dolls and they do things that are kind of a little bit more feminine, make house. That doesn't necessarily mean that that the child is going to be a transsexual. Sometimes you can have that conversation with a family members if they seem open to it, but that's one of your assessment to see how do you feel about that, is generally how I would go about talking about the gender preference of the child, because it develops at an early age. Let's see, to encourage or not to encourage, that's the big question really when it comes to transsexual and the child developing some preference for something that's not the norm. So one thing that I recommend, and even the book said it, is to encourage counseling and seeking moral leadership. So that's something you can do just as your basic recommendation in teaching for families like that. So intersex, these are people that are born with ambiguous sexual organs. In fact, it was Dr. Blackburn who just interrupted my earlier slide, and she mentioned that she, on many cases, because she's a neonatal nurse practitioner, that they have had babies born with, say, labia. However, the clitoris looked abnormally large, and so at closer inspection it could possibly be a penis. So it was very difficult and challenging for the family members to know that their child has ambiguous sex organs. And that's whenever they consulted neonatal endocrinologists, and that doctor would further investigate what hormone levels are highest and most prevalent, and then the family has to go through lots and lots of counseling about how to proceed helping this child develop and identify what gender they more or less are assigned. So, she also mentioned that some kids are born with a penis and testicles, and the child also has a pair of ovaries and a uterus and fallopian tubes, and you don't know that until a lot later. So that's very interesting about these intersex people. So, cross-dressers, also known as transvestites, these people occasionally or frequently wear clothing that's typical of the opposite sex, specifically undergarments, and it's used as a form of sexual expression. So these people carry out their behavior in secret, but a lot of times they will be more than happy to tell you about it. In fact, I had one gentleman who, what did he do? It was just casual conversation, and I talked about, so whenever you get discharged, you can have somebody to help take care of you, and he said, oh yeah, my roommate. And then, even though he says, now, we're not together or anything, I said, no, I didn't assume anything. And in fact, he went into tell, and just to let you know, it's not wrong to wear women's underwear. And it caught me off guard, and I said, no, sir, not really. And he says, just because a guy likes the feel of it doesn't mean that he's necessarily a cross-dresser. And I was like, and I asked him at that point, I said, do you have anything you want to talk about? And he said, no, I'm just fine. I'm just stating a fact. So I was like, okay, all right, moving on. Let me give you your pills. All right, sexual orientation. So, typically your sexual orientation means it's your tendency to feel attracted to people of a certain gender. So I can't remember if I mentioned this in class, that there is a theory that more people have some attraction to the same gender, but society influences otherwise, and they squelch homosexual relationships. So that is a theory. It is not necessarily proven. However, that does come to say, if you're wondering why and how there are more and more people who are claiming to be homosexuals now. So I don't know if it's just more people have had these tendencies and now they're coming out, or if it's something genetic wise, but and that society has been sequestering more or less and preventing folks from coming out. Anyway, long story short, science does not technically understand what makes up sexual orientation and how it develops. It says in your book that more professionals are concluding that people are recognizing their sexual orientation versus choosing. I will let that be your question to ask yourself, and you seek that answer out for yourself. But the appropriate and culturally sensitive words to say sexual orientation versus sexual preference. So once again, a recognition versus a choice. So how you feel is another thing, but that's just how society is now terming it. So make sure I covered everything. Yeah, I mean, obviously you know the difference between heterosexual, homosexual, and bisexual. Alright, I won't spend much time on here, but school age through puberty. This is where most individuals identify which sex they belong to. So the boys and girls, they kind of separate. They will stay with their same-sex friends. They're aware of their gender identity, and if they have an attraction to a gender, it normally occurs here. So boys will start liking girls and girls will start liking boys. If you look at birth through preschool, they don't really have a preference. They just kind of play with whoever's available. But young adults, now, they often wonder, and this goes for males and females, if sexual behaviors and responses are normal. And if I were to talk to the females, they are never really sure in this development stage if an orgasm is good enough, if they're doing it right. They're really unsure, and just there's a lot of ambiguity in the young adult phase, and they need a lot of birth control, sexually transmitted disease prevention education, as well as communication whenever it comes to sexual desires and preferences. And when they speak with their partner, sometimes we have to encourage those in the relationship to speak up and communicate their needs. So, middle adults. These folks are most severely or most seriously affected by stressors related to roles. So when it comes to their sex life, it's usually suppressed and they're fatigued. They have the same sexual desires and drives as the young adults, sometimes even adolescents. However, there's a lot of stress in their life that prevents them, and so they've expressed a lot of dissatisfaction when it comes to that area. So if you have a conversation, know if they're in the middle adult phase of life that they're going to have probably a negative view of sexual health, and it's not going to seem essential. It's just kind of on the side as far as health issue goes. So aging adults. For men, you have erectile dysfunction, and for women, you have menopause. There is a great box that I want you guys to look at. It's on page 859 in volume 1. That talks a little bit more about the sexuality development. Okay, I'm sorry. Let me go back. I misspoke. That box that I'm talking about here, box 33.1, it's regarding the aging, the effects aging has on men and women when it comes to their sexuality. Alright. I don't think I like that clicker. Let me go to this clicker question. I didn't like the other one. A 19-year-old client asks if he is normal because he always viewed himself as female. Although he has acted like a male to please his parents, the nurse should provide the client with education on which concept: intersex, transsexual, transvestite, or bisexual? I'll give you a second to answer. Answer is... Don't know how that happened. B, transsexual. Transsexual is the concept that describes people who identify with the opposite gender. A bisexual person is attracted to both genders. A transvestite is also known as a cross-dresser. This client has been functioning as a male, and there's no indication that he has worn women's clothes. Don't read too far into a question. Now, intersex is a concept that describes a person with ambiguous sex organs, or hermaphrodite. So they're intersexed. Factors that affect sexuality. This we could talk a lot about here, but I'm going to hit the high points. So, the culture heavily and powerfully influences the way we think of gender role, gender identity, marriage, even sexual expression, and social responsibilities. Huge. I don't know if I can emphasize that anymore. However, though, it's not unusual for people to be ethnocentric. Are you familiar with that word? What ethnocentric is, it's in our culture, our sexual behaviors are we, as we feel them, are the norm for everybody else. So kind of like the way you were raised, the way your parents taught you, that is your norm, and you feel that that is the norm for most of everybody else, or at least it should be. So incorporate whenever you see somebody's culture, such as they've been raised by two moms or they've been raised by two dads, that is what they know is normal. Religion. So this is also another powerful influence affecting folks' sexuality. So like some religions really restrict premarital sex. I mean, for very good reasons too. Birth control, they don't feel that birth control is good and that it's abortifacient, that's the word. Homosexuality, also extramarital relationships. So if somebody was married to, male's married to a female, however he went and had a relationship with another female, so religion would have an opinion on that. Masturbation, a lot of religions feel that that is bad and dirty, and some religions have rules about body coverings. So, covering the head, to not have your head covered, is deemed very immodest and disrespectful, especially to your husband. Modesty, so it's the issue of, is skirts okay or is pants unacceptable? Restricting opposite gender healthcare providers. So pay attention to the religious preference of your patient and just pick up on the cues. So the lifestyle now, this is something that comes from your experience. So your family, they may be, or the patient's family may be more accepting of a gay or lesbian relative, or being raised by a same-sex couple. So their lifestyle may have incorporated a new norm. So you have to kind of recognize that. Let's see, what else? Oh, if somebody is, has a very busy job and they're super dedicated to it, they may be too tired for sexual activity. So you kind of have to dig a little bit to see what or how somebody's lifestyle has affected their relationships, especially abusive relationships. If they are with somebody else who has more power, per se, say this person brings in the income and then the female stays at home, a lot of times there can be an abusive relationship there just because of power. Alright, no knowledge about sex. So we can't assume that a married woman is sexually active and sexually satisfied and has all of the information that she needs. I can tell you from experience that I had a female who, who's 50, 58 or something like that years old, and she had to have a hysterectomy for one reason or the other, and so I'm assuming that this 58-year-old would not necessarily be sexually active. That's what I get for assuming. And so I almost didn't talk about pelvic rest. However, when I got to the part, I said, you know what, I'm just going to say it. Make sure you're on pelvic rest for 6 weeks. And it was so funny. She turned to her husband. She said, I told you so. She goes, he wanted to take me home and have sex today. So I'm thinking, oh no. It's important not to let our assumptions get in our way of how we talk about culture and sexual behaviors and how that all works. Health status. So those diseases I have listed there, such as diabetes, heart or respiratory disease, cancer. I mean, like diabetes, they have problems getting an erection. That is very difficult for them. Respiratory or heart disease, these patients most often have activity intolerance. So how are they supposed to have a satisfied marriage or relationship if they, are incapacitated to, perform sex? That takes a lot out of you. Also, your cancer patients, they have a lot of times trouble with like pain or fatigue. Sometimes even the partner of the person who has pain won't want to have sex with them, just the very fear of the person being fragile and increasing their chances of death. So that cancer patient feels a little bit more kind of isolated. Our spinal cord injury folks, I have a friend who dove into a pool, 25 years old, 2 kids, been married a couple of years, and now he's paralyzed from the neck down. What is a wife to do when she has a husband who has got all this altercation and now their private life? So that's definitely going to affect their sexuality. And surgeries, I know several people who very, very hesitant and put off a mastectomy. So they had breast tumor and they put it off because they felt very strongly about their identity was related to their breast. And so in some cases, I know probably one where they let the tumor grow and they felt that they weren't going to be loved by their spouse anymore because that was the spouse's favorite thing about this person. And a lot of times patients refuse one chemo over another because they don't want to lose their hair. That is their sexuality, having this long, pretty hair. And obviously when you have chemo, some chemo, it all goes away. Surgeries, another thing I want to talk about is colostomies. That alters your sexuality. Nothing like a colostomy hanging on your right or left stomach. It's kind of hard to hide that. Mental health disorders, you don't need help really understanding that. Medications, as I said earlier, many hypertension and cholesterol medications I may not have said it, but for respiratory or heart disease, those meds have, unfortunately, negative side effects for when it comes to sex. Either females, it dries them out, lowers their libido. For males, it causes erectile dysfunction and lowers their libido. And also, you have to look at Viagra. That's always a hard top one when it comes to administering nitroglycerin to somebody. Why is the question? Do you know why? I just tell you, causes a dangerous drop in blood pressure. Cannot give somebody who has been on Viagra nitro. Bad, bad, bad. Another thing I want to mention is that the dangerous effect of having nitroglycerin and Viagra on board is that it can cause over vasodilation of the man parts, the members, penis, and and basically with it being so engorged, that's a medical emergency. They have to come into the hospital, and what do they do to it, Lori?
I don't know how they do it, but I know they do it.
We don't know how they do it, but they get it down.
Worked in a nursing home and they had to use about 3 days, but that's what they did.
I do have an interesting story that I came across over at Baptist. I shouldn't say Baptist. Well, it's too late now. We had a gentleman come in because too vigorous sexual activity caused the penis to bend, and more or less it snapped, and the columns that are inside, I think they're called the corpus callosum, it ruptured, because of one angle or another wasn't right, and it basically has caused such severe edema and bleeding into that area. He actually went in for emergency urologic surgery, and they had to repair the corpus callosum, and they had to give him a catheter because he wasn't able to void, and that's a big cause because of why? Urinary retention, and that can be a medical emergency too. So we saved the patient. He was okay. He was on pelvic rest probably a long time. He wasn't my patient, but I was just on the floor when he came. Let's see. Sexual response cycle. You've got different phases here to sexual response. Desire, the excitement, the plateau, the orgasm, and resolution. Those, just for your own kicks and giggles, and because you need to know them, go ahead and look them up in your book all by yourself. I don't think you need me for that one. Forms of sexual expression. So many ways that you can show somebody you're interested in them. Well, not so much interested, but many ways that couples can express themselves sexually. So there's intimate relationships. This is where individuals are willing to take that risk and offer trust. Intimacy involves openness, mutual respect, caring, commitment, protection, honestly, honesty, didn't play on words, and devotion. So if you have somebody who is in relationship, sometimes you can directly talk to your patient about, do you have a mutual respect for each other? Sometimes you can just gather this data by watching the interaction between the patient and their family member. Are they honest? Do they seem to be devoted to each other? Do they talk positive to each other? Do they talk down? If you identify something isn't, say, so positive in this intimate relationship, sometimes you can bring the topic up. But I will say that we often think of intimate relationships as sexual, but this is not necessarily always the case. Many sexual relationships occur without the intimacy. It's kind of the love them and leave them mentality. So, fantasies, erotic dreams. Don't feel that I should necessarily describe this, but it increases, I'll say this, self-esteem and sexual arousal, and it serves as an outlet to explore sexual desires. So if you have somebody who's extremely dissatisfied in their sexual health, sometimes you can ask, share with them that they can read or listen to some erotica or play out a fantasy. I will say people in long-term monogamous relationships, sometimes their relationship can dull down a little bit over so many years that you can encourage them to kind of play out in a sexual encounter, and that will help spice things up for them. So, self-stimulation. This is synonymous for masturbation. Many techniques. I won't go into exactly how to do it. However, young children, if they were to do this, which is not uncommon if they do, and a lot of times they don't know what they're doing. However, they quickly learn it's not acceptable and something that should be done in private. You can encourage parents to have an open conversation with the child when they kind of self-discover themselves. It is not horrible, and it's not that the kid is evil or anything like that. It's just you have to bring context to kids because they're discovering, hey, I have this body part, what does it do? Or, for females and for males, more or less, they're just discovering that if they touch here, they feel this. So we just have to make sure we bring context to the kids to show them good touch, bad touch, and even with others touching them. So, shared touching. If we have somebody who honestly is disabled for one reason or the other, or they have respiratory or cardiac problems, sometimes you can encourage them for shared touching. This is how they express themselves sexually. So, mutual masturbation. There you go. Sorry. Alright. This is really rough. Oral sex, intercourse. There is a variety of things that the book describes. I'm just going to have to say, look it up yourself. In intercourse, a lot of times you'll have, if you open this conversation doors to females, some women will mention that it's really hard to achieve orgasm. You have to honestly confirm with them that this is normal, and because they feel that they are abnormal, they automatically think of themselves as the exception. And it's important to reassure them that females have a harder time to reach orgasm, and it doesn't mean that they don't like their husband or their partner or whoever. It just means that's the female anatomy and that's how it works. So, celibacy. Some people remain celibates for religious reasons, and others because it's out of fear. They may have been a rape victim, or they're widowed, so they kind of have a lack of desire now for intimate relationships and lost their loved one. Sexually transmitted infections. There is a list of infections in your book. I would say you need to kind of know the general infections that you have there, such as chlamydia, gonorrhea, syphilis. The main thing that we want to teach our patients about these is that 2/3 of it occurs in younger individuals. So knowing that this is the highest risk group, we need to initiate that conversation. A lot of times they are going to be very quiet when it comes, or even deny. If I do have a adolescent or young individual who denies having like sexual encounters, go ahead and educate them anyway. Say, okay, well, when you do, because not that they wouldn't want to be honest with you, but sometimes it's hard for them to discuss those personal things with you, the healthcare provider. So, main thing is, if it's left untreated, it can cause serious problems, and most of the time, kids are not going to admit, even if their parents are right there, that they've been sexually active. Can I just say, not even, but especially if their parents are right there. At this point, a lot of times it's okay to ask the parent to step out for a second. You have a couple of questions that you want to ask in private. If the parent refuses to leave, you just kind of reinforce one more time. Tough situation. I can't exactly give you advice on that one because everything is situation dependent. Dysmenorrhea. This is painful menstruation. It is when the uterus has really strong contractions, and it actually causes ischemia of the uterus. So really common around adolescent and women who are going through perimenopause. The pain from this is pretty rough. It's cramping, you have lower back pain, sometimes even thigh pain, lots of headaches, vomiting and diarrhea even is some responses. What you do for this patient is they need to actually go on bed rest. Stay still, stay calm, sleep a little bit, sleep it through. You can actually apply a heating pack to the back and to the abdomen, and that helps with the pain. To give them pain medicine, a lot of times aspirin and like an NSAID such as ibuprofen or naproxen will work. Premenstrual syndrome. So this is PMS. A lot of times people will actually say while they're on the cycle, oh, I have PMS. But no, it actually occurs 3 to 14 days before the onset of the woman's menstrual period. So guys, if you're, female patients are like clockworks, and they start to kind of be labile when it comes to their emotions. They're anxious, they're irritable, and unable to concentrate. Sometimes you can even, clock it to the day that they are experiencing PMS. So another couple of signs and symptoms of PMS is constipation, breast tenderness, weight gain. It goes away. It's just you're holding on to water because of all the hormones. So, negative intimate relationships. So this is a big sexual problem. So couples are together, however, it's like a celibate relationship. They have no love, and a lot of times they're together just for social status or the sake of the kids, or even for financial security, like they just can't separate. So, or if they're, say, in a Catholic relationship, or even Muslims, I think it's very frowned upon to actually get a divorce. So, those are called negative intimate relationships. Now, the most negative relationship is called domestic violence or intimate partner violence. This is when one in the relationship is either physically and or emotionally intimidated, assaulted, and raped. Non-consensual sex. Sexual harassment. So a lot of the times we think of sexual harassment as male on female. However, it can be the other way around, such as a woman in power can be continuously stating sexual innuendos and touching and grabbing a guy or rubbing his thigh or something like that, and the male won't want to say anything. You may or may not like it, however, he can't because he's afraid to lose his job. And same for the females. If the females get harassed, they're afraid of the repercussions of speaking up because of this power imbalance, and you kind of keep silent and you suffer physically and psychological effects of that, of people constantly making sexual remarks or touching you with or without penetration, honestly. That's sexual assault. Excuse me, let me back it up. Sexual assault, let me define that for you, separate from sexual harassment. So sexual assault includes contact with or without penetration and touching sexual or intimate parts, and any unwanted sexual activity in situations of intoxication, coercion, or misconception. The word on the street is no answer does not mean yes. So if somebody advances toward you or even you're talking to your patient and they're kind of in a relationship where you're sensing domestic violence, no answer does not mean yes. So, rape. Rape is either vaginal, anal, or even oral. It's when somebody forces, either by threat of bodily harm or when the victim is incapable of giving consent, such as they passed out from too much drugs or alcohol. In all state laws consider rape, even within a marriage, a crime. So just because somebody's married, it doesn't mean they can't be raped. Let's see if I said that right. Even if you're married, you can be raped. Yes, that's it. Even if you're married, you can be raped. So you have a couple different types of rape. Group rape, that's another word for gang rape. Often drugs or alcohol are involved. Statutory rape, this is whenever an adult has sex with a minor, usually age 14 to 18. It's state dependent what they consider a minor, even if it's consensual. So even if the minor says it's okay to have sex, that's considered statutory rape. Then you have date rape. So that's when you go with a person that you know and they take advantage of you. So it can be an acquaintance, a boyfriend, or girlfriend. Now, I will say most often date rape victims don't come forward because they feel that they are they contributed to the rape. Either they were vulnerable or they dressed in a certain way and that provoked somebody to rape them. So if you hear of this or you in conversation with your client notice that they bring this up, you need to confirm to them that that's rape, even though it was somebody you knew. So, let's see. Other problems. Dysfunctional intimate relationship. Let me keep going a little bit. Sexual response cycle disorder. So you've got somebody who's got low libido. So this can be for both men and women, and they could have, for one reason or another, a hypoactive sexual desire. More often, your reasons are negative attitude towards sex. It's boring. They don't care for it. It hurts. A person may have sexual trauma, so they may not even want to think about it or come close to it. Negative relationships, which is something we discussed earlier. Negative intimate relationship, and some biological factors. So just not interested in, that's because they have low testosterone or they're going through perimenopause, and even various medications can cause, actually a lot of medications can cause low libido. Let's see, it also can be transient. So there could be periods of whenever somebody has a low libido, or it could be for a very long term, both of which are very troublesome to your client. There's arousal disorders. So it can manifest itself as, for girls or for females, just absent pelvic congestion. So they can have sex and not even feel like that was a good time. Vaginal lubrication, even though the desire there. I'm messing this up. There's a couple of reasons, more or less, arousal disorders, by definition, is decreased sexual desire. So if you have somebody who's got arousal disorder and they mention that they can't have an orgasm, so you can start talking about, the hormonal changes, aging process that's normal in aging. If they use tampons, it could be drying them out. Medications may be affecting them. Antihistamines can cause vaginal dryness. In fact, whenever you have somebody who's too dry and it causes a lot of pain, that's called dyspareunia, or painful intercourse, which, as you can imagine, would decrease sexual desire. So the recommendation is to use a water-based lubricant or saliva to help resolve this vaginal dryness. So, problem solved. Orgasmic disorders. So this is a delay or an absence of an orgasm after a normal sexual excitement phase. So they go through the sex cycle, but then it drops off. So for guys, they can even have a premature ejaculation or a retrograde ejaculation, otherwise known as shooting blanks. Sorry, I'm not alone in my office. So women, they can have orgasmic disorders related to sexual trauma. Once again, poor sexual communication with their partner. They can have a medical condition, and I mentioned this to a few girls in class. This is very prevalent in young women who have had no sexual experience, or they learn, or they're unaware of how to reach orgasm. So whenever you have young females and you do a sexual history, you can just straight up ask them, do you enjoy sex? And see where that leads you. 9 times out of the 10, they're going to tell you no. And that's where you have another conversation. Okay. Ineffective. There's a couple nursing diagnoses that you can assign to these patients whenever you identify this. I do want to differentiate one from the other. Ineffective sexuality patterns. So even though there is much overlap in between the two, the main difference is that ineffective sexual patterns is that when the patient reports difficulties, limitations, or sexual changes in sexual behavior. So they talk about changes in behavior or activity, or even their limitations. I just basically said that backwards. Sorry. So sexual dysfunction is a little bit easier to explain. It's more specific, and it really focuses in on the physiological problems. So I guess you could think of ineffective sexuality patterns as psychological, and then the other one, sexual dysfunction, as physiological. And the person is concerned about their performance. So one versus the other. You can have different etiologies when it comes to sexual dysfunction, such as sexual dysfunction related to change of interest in self or others, or sexual dysfunction related to seeking confirmation of desirability. So I pulled those straight out of the book, FYI. Let's see, how about my man who asked me if there was a problem wearing women's clothes or women's undergarments? Would he have sexual dysfunction or ineffective sexuality patterns? He would have ineffective sexuality patterns. There was nothing wrong with his actual function and performance. This is fun. Okay, etiologies for nursing diagnosis. There's actually a lot here. Activity intolerance and fatigue. This can be related to congestive heart failure or even a dialysis patient. Impaired physical mobility. So this person is more likely to have spinal cord disorders, Fear, that's another big one. Heart attacks. There's fear that if you have sex and you have previous cardiac disease, that you will, have another problem again. So that makes them stay away from sexual activities. Chronic pain. Think of those with fibromyalgia. Chronic low self-esteem. Who has low self-esteem issues? Those with ostomies. They have problems with that. A lot of times you can just put on some, or make a recommendation to put on some kind of special lingerie and they should be good. Lingerie that covers that area, or that may not be see-through right there. So there's ways to get around it. Self-care deficits, and delayed development. So this is somebody who is developmentally disabled and they have a very hard time seeking out and understanding sexual relationship. These folks are very, very prone to victimization. I mean, very. So anytime you have somebody who's mentally disabled, sometimes you have to do a little bit of a conversation. You have to have a conversation with them about that. But be very careful because they have limited ability to understand exactly what you're talking about. So don't lead them, just ask them what they know. How do I go about asking these questions? Very, very carefully. So a lot of times I would start in by saying, are you having any problems urinating? Or do you have any problems with your bowel functions? When was your last bowel movement? I kind of start going and asking questions regarding that sort of area, their pelvic region more or less. And then your next sentence is usually, are you sexually active? Yes or no? If not, have you ever been? And sometimes you could say, it always depends upon what they say and what direction you're going to explore. But assuming that they say no, sometimes I notice, especially in my adolescence, I say, have you ever noticed any redness, swelling, or discharge? I mean, itching or odor in the genital area? And then yes or no, go from there. And then have you noticed any asymmetry, lumps, or masses in the genitals or the breast? And if so, can you describe them and or show me? Excuse me. So then your next question can be, do you have any concerns about sexual function, level of desire, activity, participation, or satisfaction? So just keeping a very matter-of-fact, kind of open, keeping an open mind. Sometimes they will spill the beans to you, especially if you have a very good relationship with them, so you've developed a rapport. These questions will, honestly get pretty honest answers. So, and then depending upon how they've answered, sometimes you could start with the harder questions is, do you have sex with men, women, or both? Then even what types of sexual activities do you engage in? So oral, anal, genital, you can go to town on these questions, let me tell you. How many partners have you had in the past 6 months? All right. Be aware once again of your nonverbal communication. If you can remember what I said in class, like keep your face straight. Absolutely, do not wear your emotions on your face. If you have to, bite your tongue so you don't make your eyebrows, come to the center or make like a furrow in your eyebrow. I don't care. Just don't make a face. And provide privacy. If you are asking these private questions, make sure if you are like say in a pre-op area to keep your voice down and quiet, and don't change your tone right when you come to that topic. Sort of lean into it and start asking more questions more quietly. And of course, watch for cues for client discomfort and concerns. Okay, common teaching topics related to sexual health. One thing we cannot assume is that because of their education, their age, or their experiences, such as say it's a highly educated doctor that is your patient who's probably 45 years old and his specialty is neurology or something like that. Don't assume he has depth of knowledge in this area, or if it's a lawyer, it doesn't matter, or even if they're from the backwoods, you cannot assume that they have a lot or a little knowledge. So regarding our health history questions, a lot of times you can just say, what questions do you have about sex and sexual health? So if they say none, I'll say, okay, let me just ask you a couple quick little ones and quiz you. You always have symptoms if you have a sexually transmitted infection, and see what they say to that. Depending upon that, you can educate them a little bit more. The only normal position for intercourse is face-to-face. Anything else is deviant or at least considered not nice. These kind of questions, once again, must come after you've established rapport. Once you've got that down, you can kind of just have this dialogue with a person. But make sure you're just open to whatever their responses are. So, breast and testicular self-exams. So, the recommendations go back and forth about when you should actually recommend a breast exam. However, it should really kind of start when women are in their 20s. And then after 40 years old, they should do yearly mammograms. So, men should always be aware and feel for lumps in their testicles and see if they might have a little hard nodule and get tested for testicular cancer. I will say the benefits of testicular self-exams hasn't been studied very, very well. However, they say that it's good to do, and honestly, what could it hurt, right? So, preventing sexually transmitted diseases. We need to talk to our clients, even though they have, they're 18 years old, they probably got it in school. You don't know if their parents opted them out to hear those conversations, or if the person was homeschooled. You need to teach them about condom use, birth control, discuss sexual feelings, activity, and having, intimate relationship or abstinence, which is usually the best way. Not usually, it is the best way to prevent STIs. Can't get an STI if you're abstinent. Contraceptives. That is also for folks who are heterosexual or bisexual. So you may want to make sure that if they do not like pregnancy, that they're on contraceptive medication. Douching. Don't do it. It is not a contraceptive, and it does not prevent STIs. Just don't do it. Menstruation. Believe it or not, I learned something new, because the book mentions that some women enjoy sex more during menstruation because the pelvis is, vaginal canal more specifically, is increased in vascularity and lubrication, and apparently increases pleasurable sensation. And the orgasm actually relieves menstrual cramps. So it goes on to say that some men too enjoy the warm, wet sensation. Well, there you go. Now we know. So just make sure you have a towel handy. The book says that. That did not come from me. Counseling for sexual problems. There is a little technique called implicit. I don't expect you to know that. That is something, if you are extremely focused, such as you work in a doctor's office and you can have these kind of conversations with these patients, would you actually use this technique? So just be aware of what the P, the L, and the SSIT stand for, okay? There you are. Which statement below is true regarding sexuality and body functions? Douching after intercourse prevents pregnancy. It is not okay to ask someone about. It is not okay to ask someone if they have had same-gender sex. Celibacy is 100% effective in the prevention of pregnancy. Antibiotics can cure all types of sexually transmitted infections. Answer is it's actually C. There you go. Celibacy, 100% effective in preventing pregnancy. Douching does nothing for you. It is not recommended. and it takes away all of the good flora that's down there. And it is okay to ask somebody if they've had same-gender sex, and antibiotics can cure some types of sexually transmitted infections. So, herpes, that's one you can't cure. It just goes in remission. If you have somebody who is inappropriate, so your patient is making very inappropriate sexual comments, the first thing you have to do is be upfront with them, be forward, and if it sounds rude, you're doing it right. You immediately tell them that the comment is inappropriate and that you don't appreciate that talk. And you cannot get angry. Some people get encouraged, honestly, by you getting angry and kind of getting a reaction from you. So just be straight-faced, as if it didn't even touch your ears or sit deep in your heart that this person just made this sexual comment to you. Tell them your expectations. So this can look like something of, I will not entertain comments like that. You need to stop, or I will step out of the room. So tell them what you're going to do if they pretty much keep crossing the line. Refocus their behavior.
Sorry.
It's okay. Here. Yeah. Then refocus their behavior. Here, I want you to hold this while I reconnect your IV, or I need you to wash your hands while I wash your feet. And if they still continue it by making these sexual comments, you basically say, if I hear one more thing, you need to stop. If I hear one more thing, I am leaving the room and I'm bringing in the nurse manager. And if that doesn't shut them down, then you actually reassign yourself. Okay, I want to talk about some drugs real quick with you guys. Nitrofurantoin. Just a few things on this drug. Most commonly used agent for UTIs is this macrodantin, trimethoprim sulfametazole, and fluoroquinolones. So as you can see, macrobid is right up there as the top one that you'll see whenever somebody has a UTI. Now, for low doses, it's considered just bacteriostatic, and for higher doses, it's considered bactericidal. What does that mean? For bacteriostatic, it just makes sure that the bacteria that's in there is, it can't grow. If it's bactericidal, it actually kills and becomes toxic to that bacteria. So, thankfully, it covers a broad spectrum of bacteria, gram-positive and gram-negative. And let's see, what did I highlight in the book here? You want to make sure that you give this food, give this drug with food, so it decreases GI distress. If you try to give it and somebody doesn't have like a cracker or milk or something down their belly, they're going to get some serious nausea, may even vomit on you. In fact, if you look at the side effects of this drug, some of it lists anorexia, nausea, vomiting, abdominal pain. Turns out you actually get rust and brown discoloration of their urine. So you might want to warn your patient of that in the event that they see that and they think they're bleeding. Just let them know that is a normal side effect of the drug and not a thing you can do about it. So, if your person starts having angioedema, which is swelling of the face, lips, and throat, that is considered a medical emergency, and you better get that person some epinephrine and a steroid, Elstato. Some other adverse reactions I want to point out is the hepatotoxicity, Stevens-Johnson syndrome, and the aplastic anemia. I've been around a while. I haven't seen that. It's kind of uncommon. However, it does still occur. So what else we want to talk about with this? Some contraindications for giving this. If a person is hypersensitive to it, that means they've had sort of not an adverse reaction, but they've had side effects that were pretty severe and caused some problems. So you may consider doing something other than this drug. Then you've got moderate to severe renal impairment. As you can see here, this drug is, or is it? I can't find it. Just kidding. I'm looking in my book for something and I'm not seeing it. Anyway, if you have somebody who's in renal failure or they have a low GFR, the last thing you want to do is give them this medicine because they're not going to be able to process it, and you'll have basically toxic levels in their system really fast. Can't give it if somebody's pregnant. It is important to find out for females who are deciding to do hormone therapy if they have a uterus or no uterus. If they do not have a uterus, meaning they've had a hysterectomy for different reasons, such as like cancer, fibroids, or uterine prolapse, or even like endometriosis, then you want to probably see them on a estrogen and progestin therapy. However, if they don't have their uterus, such as they have had a hysterectomy, then they can just go on regular estrogen therapy, because this is really good for you to use for women who are struggling through menopause. The symptoms of menopause are pretty challenging because it's hot flashes, so you strip down to naked in seconds, then you have, or you feel like you need to strip down because it's just too hot. You have also vaginal dryness and some sleep disorders. So a lot of women will go on estrogen therapy if they don't have as much, if they don't have risk factors for it. Hormone therapy is an available drug that you can take orally. You can actually put it on a patch, or you can actually apply it vaginally. So I'm going to specifically speak to the pill form, which is mainly known as Premarin. You will see that in the hospitals a lot, actually. The reason being is it's well tolerated by most patients, and it's pretty easy to administer. And you just do it once a day, usually in the evenings. If a person experiences like GI upset, usually nausea and vomiting, you can actually give it to them with food. One thing that is great about hormone therapy, besides all the different risks, is that it actually increases your HDLs. And if you remember what your HDLs are, that's high density lipoprotein. This is the cholesterol that actually goes to your vessel walls and collects the cholesterol that was deposited there and brings it back to the liver. So, okay, so why is the reason, we know why we want to get it, to decrease hot flashes and all of the problems with menopause. What is some reasons why you can't give it? So, if somebody is pregnant, you better not let them come near it. In fact, if you have a patient who is requiring this drug, I just recommend using gloves. Not that the pill could be absorbed through your skin, but specifically the vaginal preparations where you would actually apply some kind of gel. I would not use that or apply that myself unless you've got double gloves on. So you don't need that. You don't need to absorb extra estrogen. If you have endometrial cancer, if you've had a history of breast cancer, because many of the breast cancers are estrogen positive, they call it HER2 cancer, so the more estrogen you actually give somebody who has these type of breast cancers, the larger the tumor gets. So obviously you don't want to give it to people who are HER2 positive. History of thromboembolic disorder, so they've had a history of clots. If they have liver disease or chronic liver impairment, if they have gallbladder or pancreatic disease, coronary artery disease, even though it has the benefit of increasing your HDLs, we do not want to give it to somebody who has diseased arteries around the heart. And undiagnosed vaginal bleeding, that's because we're not sure if the patient has endometriosis. So, if a person is a smoker, that's a pretty good indication that they should not be on estrogen therapy. In fact, their risk of clot has just gone up like tenfold. So if they are a smoker, they should not be on estrogen therapy. Also, history of fibroid tumors. So then the last thing this person needs is to feed the tumors and have them get bigger, more or less. Okay. I pretty much went through the the contraindications and some of the side effects. So, okay. As you see here, I also have some things posted that you can review. Where's my mouse? Significantly improves vasomotor symptoms and vaginal dryness and decreases the risk of osteoporosis. It actually helps with calcium absorption. So if you look, one of your adverse reactions is hypercalcemia. So if the drug is helping, we don't want it to help too much. So yeah, we like to take it for osteoporosis, however, it can be too effective sometimes. There's a lot of factors that go into play for that, but we just need to watch for hypercalcemia. Use the lowest dose possible for the shortest duration, usually less than 5 years. I've read somewhere 5 months. We'll let the doctors decide that one. Maybe that was just cohosh that we had to use less than 6 months. Yeah, that's it, actually. I knew 6 months stuck out to me somewhere. Okay, that's that about that. One thing I want to talk about on that table on page 882 in your Keys book is the treatment medications used for BPH. So what I have here is you can use a few of them. Alpha adrenergic antagonists. So remember when we talked about alpha adrenergic drugs? These are the flight system. So this is actually going to relax the bladder and relax the prostate. So people who can't pee, such as men with prostate problems, can. We have anticholinergics, phytotherapeutics, phyto meaning plant. The guidelines do advise discussion of benefits and risks for each recommended treatment, such as the patients who are on these drugs are going to have decreased libido and erectile dysfunction. Kind of a hard decision to make whenever you are trying to prioritize what's most important for you. Do you want to dribble, or do you want to have sort of a unsatisfactory sex performance? So a person needs to kind of be aware and understand that. And you should have close follow-up with them every 1 to 3 months, depending upon which class of medicine that they take. If a person is taking tamsulosin or doxazosin, also known as Cardura, those are for the prostate. However, sometimes you'll see terazosin and doxazosin given for blood pressure. So even though a person is getting the benefit, say somebody who's taken doxazosin for the prostate, let them know that it is also given for blood pressure. Therefore, it is going to also lower their blood pressure and give them that postural hypotension, or what we say orthostatic hypotension, dizziness sometimes, and fatigue. So they need to be aware that it's also given for different reasons. So, I see here to avoid hypotension, ask the patient to take this at bedtime. Also, that's a very good thing to do, is because it's most effective right up front. And when this person needs to go to the bathroom, they need to go to the bathroom, empty their bladder at night, or right before they go to sleep, empty all of the urine, and they won't have as many frequencies throughout the night waking up and having to go pee because they've already emptied all of their bladder. So another perk to taking these drugs to help your prostate, at night. Another thing too that we want these folks to avoid is medications that cause urinary retention. Talked about this earlier. For females with bladder problems, this causes the bladder to relax and be less spastic. So if they can't already go because of constriction, don't give them an anticholinergic, antihistamine, or decongestants. Not going to do well for these folks. Okay, I think that's all I want to say on that. Yep. Okay, last but not least, when it comes to the chapters in your Iggy book, I really want you guys to focus on some charts. Okay? So the charts I want you to focus on is chart 66-1, which talks about minimizing catheter-related infection. So know that material in there. Chart 66-2, that regards preventing a urinary tract infection. Let's see. I want you to know chart 66-3, which is the key features of urinary tract infection. Going through here. Page 1375, chart 66-5, the factors contributing to urinary incontinence. This material in here pretty much states what I mentioned in class. It adds some value in regards to extra information. However, I really think if you guys study those charts that I'm talking about, you should be okay. Then chart 66-7, which is education regarding pelvic muscle exercises. Please know that I will be asking you questions regarding to that. My last one, this once again complements the material that is in your W&T book, and it's on this last chart is found on page 1381, and it's bladder training and habit training to reduce urinary incontinence. So let's see. I'm trying to see if there's any value in chart 66-10. No, not really. Okay. The last thing I want to mention is chronic kidney disease. Boy, this is extremely in-depth when we talk about chronic kidney disease. However, I just need to introduce you guys to it, which means you need to kind of have a basic understanding. So, if we look at table 68-7 on page 1419, it talks about the different stages of kidney disease. And I think I mentioned it in class. The lower your GFR, the worse your kidneys are doing. So as you see on this table here, stage 5, a person has a GFR of 15 milliliters per minute. That's a pretty bad filtration rate. They may still actually make urine, however, this person needs dialysis. Many causes to chronic kidney disease. Oh goodness. Tell you what, I feel that the most important thing that we need to focus on is prevention right now. So that would be on on page 1422, that's chart 68-3, and it says prevention of kidney and urinary problems. And if you have somebody who has kidney disease, we need to manage their fluid volume. So I want you to look at the chart on 1426, which is labeled managing fluid volume. If we start there, that's going to be a nice little intro of chronic kidney disease, because it is so in depth, and at this point you guys may not be there yet whenever it comes to getting this type of information, because you're learning so many other things. So, alright, that's what I want you to focus on in those chapters. So, if you have any questions, post them on the discussion page. I appreciate you sticking with me and actually listening for, an hour or something now. Thank you guys. Have a great day. Once again, if you have questions, just post them. Have a good one.